Hi, I'm Dr. Thais Aliabadi.
And I'm Mary Alice Haney. We started the SHEMD podcast to empower you with the information you need to be your own health advocate.
So today I will be answering your questions on everything from birth control to HPV, PCOS, endometriosis, and menopause.
Make sure to send your questions to info@shemdpodcast.com so that you can be featured on the next Ask Dr. A episode. Thanks for tuning in to SHEMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SHEMD, some of the products and services we discuss may involve sponsorships or paid advertising. All right, this is our very first Ask Me Anything episode with Dr. A. And before we get started, we've gotten so many questions sent to us that are great. And I think you are going to be excited to hear them and answer them. And I also want everybody to kind of get to know the two of us. We've had the most incredible, amazing guests on our podcast, but I also think you're one of the most incredible doctors in the world and you have so much expertise. So we're going to start that today. Are you excited?
Sounds good.
Well, first of all, you just came
it's
from
completely random.
Completely random. I'm going to ask you these questions. These were from our listeners and viewers, and I want you to answer them. But what have you been doing before you got here today? Today is, just so everybody knows, I don't know what day we're going to air this, but it's a Friday, and Friday is your surgery day.
It is. I've been running around since 6 a.m. I did 2 endometriosis surgeries this morning, and my last surgery was this 14-year-old girl. You know, I don't know, maybe in my lifetime, I'll see 2 or 3 of these in thousands of surgeries. This was the first one like this that I saw today. This is a 14-year-old who came to me from Northern California. She had seen 5 physicians, OBGYNs, because since she got her period, she has just excruciating pain. On the floor, doubled over, misses school, can't function, ends up in the emergency room. That's not normal. So, but the problem with her was she went to doctors, and because she was 14, they couldn't do a pelvic ultrasound. On abdominal ultrasound, they couldn't really see much. They did an MRI, and she was told that she had an ovarian cyst with a pelvic kidney. So a pelvic kidney is when your kidney, instead of being up in the back, it's basically in the pelvis. So she presented to me, and the mom said, you know what? She is dysfunctional. She doesn't go to school. She just can't function. She's in so much pain. Something's getting missed. And as you know, those are the patients I see in my office.
I know. The ones that nobody can treat.
And nobody can treat. So basically, I did my own ultrasound, and I'm looking at her ultrasound. I'm like, her ovaries are, her right ovary is full of blood. But then there's another structure next to it. So the way I thought I read it was her right tube was full of blood and her ovary possibly was full of blood. Remember, this is all abdominal. Mm-hmm. But everything looked abnormal for her age. So I said, you know what? I don't agree with that MRI result. And she had taken this MRI read to all these doctors. I'm like, can I have the disc? And obviously they didn't have it. They went back home. They sent me the disc. I uploaded it to Cedars-Sinai, and I had a radiologist read it. He called me 2 Fridays ago, and he said, this is a very interesting case. This girl has basically duplication of her uterus.
So she's got 2 uterus.
Yes. Well, 2 halves.
Okay.
The left half of her uterus, which is relatively normal size, is attached to the left tube and the left ovary. Mm-hmm. Her right uterus is not attached to the cervix and out the vagina. So every month when blood accumulates in the right horn of the uterus, there's no way out of it.
So what does it do?
It stays inside the uterus, and because it has nowhere to go, it would push out of the right tube. So her right tube pretty much was completely dilated, full of blood. And from the tube, blood was going into her abdominal cavity. And therefore, this morning, I knew it going in, but she also has endometriosis because these uterine cells were pushed out of the tube into the pelvic cavity. So I operated on her this morning. I removed her right half of the right part of her uterus, which was not connected anywhere. I removed her right tube. I removed all her endometriosis. It was really sad. When I came out and spoke with her mom was she couldn't even stop crying. I can't even imagine, as a mother of 4 daughters, what do you do when you keep taking your 14-year-old daughter who's had periods for 2 years from doctor to doctor, and everyone says there's nothing wrong with her?
Yeah, I think the lesson that I'm learning on this podcast and with you is you have to be your own advocate, or if you're a mama bear or a dad or a parent or anybody in your life, you have to advocate for these children.
But what's advocating? Like how many visits could you possibly go to? 5. And what the mom told me, she's like, if you couldn't figure this out, we wouldn't know what else to do.
Right. All right.
Do you know? And the lesson from this is, and I think this is a lesson for all of us physicians, even me, like I might get a report for a breast MRI. I don't know how to read an MRI.
Mm-hmm.
I'm not trained to read. I'm not a radiologist. So you trust that report, right? What else can you do?
Right.
But one thing you can do is question it.
Right. And I guess that's what we're saying is as a doctor, you have to trust the other doctors and the radiologists and all that. But if something still doesn't feel right, you have to question it again and question it until you get the right answer.
And you know what I did? Because the read at Cedars-Sinai was so different. You would think they're reading 2 separate reports, right? I called the radiologist. I'm like, how could this be? How could your report be so different than another radiologist in Northern California? So, you know me, I'm like, I need a third opinion. So I got another radiologist at Cedars-Sinai to read it, and his report was identical to the other physician at Cedars.
And that was the information.
Exactly.
Right.
And these guys are so amazing. I actually FaceTimed the radiologist when I was in the operating room because I operate laparoscopically and we have a monitor. Mm-hmm. So my nurse showed everything he told me over the phone was everything I saw in this girl's pelvis.
That's amazing.
It's amazing. That's why it's so important. It takes a team, right?
Yeah. As
soon as I finished my surgery, Dr. Yaniv Raphael is the radiologist at Cedars-Sinai. I just absolutely adore him. He's so well trained. He's so smart. And I called him and I say thank you, because if you also agreed with the other doctor from Northern California, then at that point I would have questioned my own.
Right. And maybe you wouldn't have done the surgery. Maybe you wouldn't have.
I would have done the surgery because she's in so much pain. Right. But this way, I had all the consents in place. I told the mom I was going to remove the right half of the uterus. You just have to be prepared. You know? A lot of times these girls have a septum in the vagina. So their vagina is also split. So, when you go in, then I resect the septum too.
What does resect the septum mean?
Like,
cut it?
Cut the septum. Okay. Like there's a wall in the vagina that can separate the vagina into a left and a right cavity.
Well, that's not what I did today. So now I'm very excited. I'll tell you what I did today. I put these questions together. So I'm very excited to ask you, because this is what we're doing. We want every girl, woman, husband, father, whoever's listening to this podcast to be their own health advocate. And starting by, you could always write questions into us, and we're going to try to get to everybody's question at some point during the season. So, all right, first question.
Let's go.
I was diagnosed with HPV. What do I do?
Good question. HPV is human papillomavirus. Please do not confuse it with herpes. These are 2 different sexually transmitted viruses. Right now, we're talking about HPV, human papillomavirus. Very, very common. Maybe 80% of us will get infected with some type of HPV in our lifetime, right? There are 100 different strains of HPV. About 30 of them affect the genital area. Of the 30, 15 of them are high risk, meaning it can cause cervical cancer.
Okay.
Right? Of the 15, Two are very aggressive, number 16 and number 18. So if you look at your pap smear report, usually it says that you had a negative pap smear. And in women within the reproductive age, we also check for HPV. And usually it says HPV high risk. You're either negative, then we're done. But if your HPV high risk is positive, you hope that the lab would reflex it to number 16 and 18. Okay. Because we want to know whether or not you have number 16 and 18. Number 16 and 18 are responsible for over 75% of cervical cancers.
Wow. Say that one more time.
So HPV 16 and HPV 18 are responsible for over 75% of cervical cancers. I want you guys to know that HPV is almost 100% preventable.
How?
Right? Well, not preventable, I guess treatable.
Okay.
Right?
How?
So first of all, vaccination. We'll go back to what it can do, but all children between 9 and 11 should get vaccinated with the HPV vaccine. This is extremely safe. My daughters are vaccinated. We're not talking about COVID vaccine. There's no controversies with this.
My sons are vaccinated.
As they should. Yeah. So we started vaccinating girls 9 to 26. But guys, give HPV to us, right? So then a few years ago, they started vaccinating boys and girls. Right. So it's part of childhood vaccinations. Parents, if you're listening, please do not decline this HPV vaccine.
So boys give girls HPV.
And girls can give it to boys. It goes both ways. So you have to vaccinate both, right? So once you get infected with an HPV virus, right? 75% chance that your body will either suppress it or completely get rid of it in 1 year.
Okay.
90% chance that your body will suppress or get rid of it in 2 years.
Okay.
Right? But with HPV 16 and 18, they tend to be more aggressive. So you have to be a little bit more careful with these patients. Now, if your pap smear comes back with atypical cells and your HPV is negative, then you can just do a follow-up pap smear 6 months to a year. But if your pap smear shows atypical cells and your HPV high risk is positive, then you need a colposcopy. Colposcopy is a procedure we do in the office. We basically put acetic acid, which is vinegar, on the cervix, and I look with a special camera, and areas that light up as white, precancer areas light up as white under my green light. I take a biopsy of those areas, send it to the lab. Usually when I do a colposcopy, I can tell you if you have precancer cells or not. So depending on the results of the biopsy, then we treat.
So what if it comes back that you have precancerous cells?
Very good question. So between normal and cervical cancer, there are 3 stages of precancer: 1, 2, and 3. Stage 1 precancer, or CIN1, low-grade SIL. Basically, these are cells that majority of them will go away. So you have 2 options in this case. A, you freeze the cervix. B, you just repeat a pap smear. In my office, I repeat pap smears maybe every 4 months times 3 to make sure I have 3 negative pap smears with negative HPVs, and then my patients can go back to routine screening, which is, for high-risk patients once a year. Low-risk patients, you can do it up to once every 3 years. If you have precancer level 2 or 3, then we need to scrape off the superficial part of your cervix. I want you to understand that these high-grade cells sit superficially on the cervix. Sometimes they can go into the canal, right, in the endocervical canal, but most of the time they're sitting on the surface of the cervix. So you just scrape off the superficial part. This procedure is called LEAP. Some doctors use a cold knife cone. I don't like cold knife cone because you tend to take more of the cervix out, and you don't really need to take that much off of the cervix. Imagine the size of a dime. So you don't really need
just a little bit.
Just a little bit. And, you just want to make sure the margins are clear, and, you take everything off. And then, I always tell patients, I can get rid of your precancer cells 100% of the time. Well, at least I've done so far for 23 years. I don't want to jinx myself. But I can't get rid of your HPV.
Okay.
HPV is a virus. Your immune system will get rid of it. So if you're stressed out, if you're anxious, if you're not sleeping, if you're not eating well, if you're smoking, anything that will lower your immune system will increase the recovery time or suppression of this HPV.
So once you have HPV, you always have it in your body, dormant?
It can be dormant, or you can get rid of it. I have patients, they show up to my office 7 years into a marriage and they're HPV positive. If you suddenly test,
and then you're like, what in the world is going on here?
Well, it could be that your partner is doing something.
Yeah.
But it could also be that it has been dormant and you've had a stressful year or a few months, and then the HPV is coming out.
That's like what my husband says. He's like, if you come home pregnant, I am going to know that it was not me. And I'm like, but it could be you. So yeah, it's the same thing. So it could be that your husband was running around on you, but most likely it's been dormant and you're stressed and it's come out again.
It's very different than your husband showing up at home or you getting diagnosed with chlamydia or gonorrhea 7 years into a marriage. Do you know what? So that's complete. But with HPV and herpes, it's a little tricky because you can't really point fingers.
Okay.
Does that make sense with HPV?
That makes plenty of sense. I love that because I don't think that HPV is talked about that much. I think we should do a whole episode on STDs
there's so much,
and HPV.
There's so much
I know.
more
So we're going to do a whole episode on that. Okay. I want to go on birth control, but I don't want to gain weight. What should I do?
Listen, low dose birth control pills do not cause weight gain. However, a lot of patients who end up needing birth control could be, for example, PCOS patient, right, has insulin resistant. When their hormones start going off, you put them on birth control, they gain weight, they blame it on the birth control. You take them off of birth control, they're still gaining weight. It's because of their insulin resistance. But there are patients who report eating more on birth control. I've seen that. It can happen. But generally speaking, low-dose birth control pills do not cause weight gain. However, if you're really scared to take birth control pills because you're worried about your weight, if you've had history of eating disorder and you're just scared and you don't want to do it, progesterone IUDs are my favorite.
They are?
Yeah. For girls who haven't had any children, they can use the Kyleena IUD, which is a small progesterone IUD. It's very well tolerated. It's for 5 years. It's progesterone only, doesn't have any estrogen, and you don't feel it. Your partner doesn't feel it. It makes your period super light. It's my favorite. If someone tells me you need to be a gynecologist on an island, what would you take with you? And there's one thing you can take, I would take a Kyleena IUD.
Really?
And I'm not getting paid by the company.
Okay. Is rectal pain normal with menstruation or linked to endometriosis?
It could be linked to endometriosis. Rectal pain could be a normal symptom of your period as long as it's not severe. Usually when someone complains of rectal pain, I start questioning endometriosis. So you want to make sure you don't miss endometriosis. As you know, it takes doctors 9 to 11 years to diagnose endometriosis. Endometriosis presents with different symptoms. It could be bladder, it could be rectal pain, it could be back pain, it could be leg pain, it could be bloating. So, if someone complains of rectal pain in my office, I will take it seriously.
And go back and listen to our Olivia Culpa episode where we go in very deep to endometriosis and what you should be looking for, what you should do if you think you have it.
Right.
Can you have PCOS if you're anemic? And is it hard to get pregnant if your iron is low?
Unrelated.
Okay.
PCOS. So anemia, usually in a young girl, obviously there are multiple causes of anemia, but in a girl in her reproductive age, when you see anemia, you have to make sure they don't have heavy periods. So that's the first question you ask. If someone has really heavy periods, that's probably the cause of their anemia. So they immediately need a pelvic ultrasound, right? You need to make sure they don't have fibroids, they don't have polyps in the uterus. You want to make sure their hormones are okay. But then if everything's normal, you do a full workup for anemia. You want to make sure their vitamin B12, everything is normal. You want to make sure their iron is normal, their ferritin level. But PCOS and anemia are unrelated.
Okay.
Because pregnant patients do get anemic during pregnancy.
I did.
Yes, it's common because your blood volume changes. That's why in your prenatal vitamin, you always have extra iron. But you don't want to start a pregnancy anemic. So it's good to get a full workup and then go into pregnancy.
Okay. I'm 42 and I'm BRCA2 positive. Do I necessarily need to do a prophylactic mastectomy?
These patients, their risk of breast cancer is above 80%. Yes, it is a choice. Of course, it is a choice. You know, I had a French woman in my office years ago. I told her she had BRCA and she was, I don't know, in her mid 40s. And I'm like, you know, in America with a BRCA gene mutation, we recommend mastectomy by age 40. And we also remove your ovaries at 40. She looked at me, she said, you American doctors are crazy. I'm not removing my breast and I'm not doing any imaging. In France, we start imaging at 50, and she left my office. That's fine. And, you know, that's her choice. I did my job as a physician to educate her, right? But 80 some percent, I think with, with BRCA, not that I think, it's 82% chance of breast cancer. So common sense would say remove your breast. And we usually recommend a prophylactic double mastectomy, meaning removing both of your breasts at age 40.
I have taken Accutane and acyclovir, and I stopped a month ago. Is it safe to start trying to get pregnant?
Let's start with acyclovir. Acyclovir, you either take it for oral herpes, like cold sores, or you take it for genital herpes. We use it in pregnancy, so there's no reason to stop it, start it, not take it, so it's fine. As far as Accutane, 1 to 2 months, and then you can start trying.
My pap smear results are back. My HPV is positive, but 16, 18, 45 is negative. Is a biopsy necessary?
Is her HPV positive?
Yep.
So if she's been HPV positive for over a year with a negative pap smear, yes. And let me tell you a story. My husband's friend from high school in San Diego, his wife passed away recently. Her pap smears were always negative. Mm-hmm. Her HPV high risk was positive. So her doctor would tell her, because your pap smear is negative, come back next year. She would come back the following year and she would have a pap negative, HPV positive, and they would send her to go again. She finally came back with stage 4 cervical cancer and passed away.
Explain to me one more time so it's very clear. If you have a negative pap smear
with a positive high-risk HPV, you can repeat your pap smear. I usually do it in 6 months. If the HPV is still positive, pap smear is still negative, I'll repeat it one more time 6 months later. But if in a span of 12 months, you have 2 negative pap smears with both times HPV positive, you buy yourself a colposcopy. Pap smears are lousy tests. Okay. You can do a pap smear on a patient with cervical cancer and it can come back as negative.
So what is the test that you need to do if that happens?
HPV is very valuable.
The HPV test. And what was the other one you just said? Colposcopy?
Colposcopy is when you get to a point that you need to investigate to see if there are precancer cells. Okay.
And how do you investigate to see if they're you put your little light on and put
and then take biopsies and send it to the lab. But let me make one thing clear for you guys. If you have a negative pap smear, but your HPV 16 and 18 are positive, you still buy yourself a colposcopy right away.
Okay.
If you do a pap smear, your HPV is positive, so you have one of the 15 high-risk types, but you don't have the 16 and 18, you can follow up with a follow-up pap smear. But if within a 12-month span, your pap is negative still, but your HPV stays positive, after a year, you need a colposcopy.
Okay. And a colposcopy, so that everyone knows,
it's a procedure we do, and we look at the cervix with a special camera, and we take biopsies of suspicious areas, send it to the lab, and then when we hear back from the lab, we know if your biopsy is normal, then you just do a follow-up pap smear. But if your biopsy shows precancer level 1, precancer level 2, or precancer level 3, then we treat it accordingly.
Okay. How quickly after stopping birth control pills do you recommend trying to start getting pregnant?
A couple of months.
Okay. Like 2, 3?
Yeah, 2.
Okay. I'd like to know if hip pain and joint pain is related to hormone levels, both increased estrogen or decreased estrogen. I feel like doctors just write this off as nothing related to a female issue when intuitively I feel strongly it is.
So it depends on your age, right? If you show up to my office and you're 30 years old and you're complaining of joint pain, I will send you to a rheumatologist. It's not normal. But if you're my age and you get shoulder pain and you've gone through menopause, then that could be normal. As we go through menopause, our joints hurt. As we get older, we get osteoarthritis. There are different types of arthritis. You can have, we talked to Kim about psoriatic arthritis, so there are different reasons why patients would have joint pain. So joint pain needs to be evaluated. If your primary care is not working you up and this is something chronic, then these patients need to be seen by a rheumatologist.
And what is a frozen shoulder? I hear this all the time with women that feel
It's
like
very common in postmenopause. I think I have it. Basically, it's pain in your shoulder. I mean, I'm not an orthopedic surgeon, but usually it's worse at night when you sleep, which is exactly what I have. And during the day, it's not as bad. It needs to be evaluated. If it's chronic, usually you can go to your orthopedic surgeon. They can give you steroid shots. They can do PRP. But if it doesn't go away, then you have to do an MRI to make sure you don't have any tears in your ligaments.
And that happens with women.
Very common postmenopause.
Yeah. And that's hormonal.
Mm-hmm.
Okay. What preventative annual test scans should 20 and 30-year-olds be doing?
If I could pick one thing for every 20, what is it?
Egg count.
I'm so proud of you, Dr. Haney, once again. Absolutely. AMH, anti-Mullerian hormone. It's a test. It's a blood test. It's simple. Any lab in this country will run it for you. It's covered by insurance. It is so easy. It's so cheap. Just do it. There's no reason to be surprised. I have these twin girls that I delivered many, many years ago. And I just checked their egg count and they're both low.
How old are they?
18.
Oh, so what happens when that happens?
So nothing. It's just awareness, right? So I'm suspecting endometriosis in them, so I'm suppressing their endometriosis. And we talked about egg freezing in the next 2 years. I have a 14-year-old in my practice with an egg count of a 35-year-old.
14?
And her mom, we don't freeze eggs under 18, but guess what she's going to do when she turns 18?
Yeah.
One thing I don't do, though, I don't discuss egg count results with teenagers, but I do discuss it with their parents.
Yeah. I think that's
so
good.
This is not something they need to be aware of at 14.
Right. But their parents should be aware.
Parents should be aware.
Okay. I have a recurring yeast infection and BV. I've been to the OBGYN, but nothing helps. Any device?
I'm so good at that.
Tell me. I get yeast infections all the time.
It's called anxiety.
I know.
I'm just no, I'm serious. So recurrent BV and recurrent yeast are very different.
What's BV?
Bacterial vaginosis.
Okay.
So let's talk about yeast infection. Yeast infection usually gives you a cottage cheese discharge. It doesn't smell. It doesn't have an odor, but it causes a lot of itching, right? Mm-hmm. These patients usually it's associated with antibiotic use. These are patients who come in, they're like, I had a sore throat, I had pneumonia, my doctor gave me antibiotics, and now I have a lot of itching. I don't even need to do a culture. I know what you have.
Yeah.
However, patients who are very stressed out, very anxious, these are patients who bounce from doctor to doctor and their yeast infections don't get better and they get upset at their gynecologist. It's not the gynecologist's fault. Usually, almost every single time when I see someone whose yeast infection has not been, resolved, it's because they're anxious or very stressed. So I always start backwards. I start talking about their stress, talking about their anxiety. So there's a way to deal with that. If you have chronic yeast and you've been treated and you have a culture to show that it is yeast, you can do diflucan suppression. You know what diflucan is?
I know it's a medicine. I've taken that before.
150 milligrams. You take it once a week for 6 months.
Really?
Mm-hmm. I usually say take it for 3 months and call me, but I give them 3 months to fix their anxiety. And if they can't fix it, then, we have to talk about medication.
Right. Okay.
But so usually I have them see their psychiatrist, their therapist. You have to, like everything else in medicine, you have to treat their underlying condition. Bacterial vaginosis, BV, gives you a creamy discharge. It's foul smelling. It smells like fish. I have a lot of patients, they come in and they're like, my partner tells me my smell is different. That's usually bacteria. You want to make sure you don't have a stuck tampon in there because that is the first thing.
And that could be toxic shock too.
Yes, absolutely. And Believe me, it happens a few times a year in my office. Number two is if you have recurrent BV and you've been treated multiple times, then we treat the partner. Okay, so we treat both my patient and the partner. In both yeast and BV with recurrent cases, one thing that I regularly use for my patients is boric acid suppositories, not the over-the-counter ones, the prescription ones. It's compounded. Usually I treat them every night for 7 nights and then twice a week for 3 weeks. And then I drop them into a maintenance dose of twice a week for 3 months. So it kind of brings the pH back to normal.
Okay.
I hope this answered your question.
It did. It was so informative.
I can talk. You have to stop me when I.
No, I love it. I'm loving every single minute of it. Tips to help with PCOS postpartum.
So PCOS prepartum, during pregnancy, postpartum, it always affects you, especially because of that insulin resistance. Postpartum, first of all, during pregnancy, PCOS patients are at risk of gestational diabetes because of that insulin resistance. So usually pregnant patients get checked between 24 to 28 weeks for gestational diabetes. Remember that drink, that nasty drink we give you to? So we do that between 24 to 28 weeks. With PCOS patients, I do it twice. I do it at 12 weeks. And if they pass, I repeat it again between 24 to 28 weeks. If they fail at 12 weeks and they get diagnosed with gestational diabetes, then we treat them throughout the pregnancy. Now, postpartum, patients want to lose weight, right? And they can start metformin for PCOS patients. As you know, that's another whole, lecture on its own. But metformin helps PCOS patients because it helps their insulin resistance. It helps their weight, so they can immediately start metformin. But one thing I always say is don't stress postpartum. Your weight will go down.
Give yourself a break.
Give yourself a break. Hold your baby. Love your baby. Just enjoy these moments. They'll never come back. Just put that baby, do skin to skin, put that baby on your chest and just love every minute of it. Don't worry about your weight.
Because it goes by so fast. And they tell you that and you don't listen and you just sort of, I wish I could have given myself a bit of a break too. I mean, I remember
We're so tough on ourselves.
I had to go to Fashion Week right when McLean was born, and I took he and Gray on the plane. And I remember I went to this first event that I had to go to, and I just was shaking because it was 3 months after I'd had this baby. And I was just I was trying to squeeze myself in my Haney dresses. And then I was, it just was like, give yourself a break and take a minute, if you can, if you're lucky enough that you can. And rely on people around you for help.
And I have a lot of patients, they're truly gifted. They deliver a baby, they come 2 weeks postpartum, and they've lost all their weight. And, I wasn't like that. At 6 weeks, I had 36 pounds to lose. So don't compare yourself to others. We are just different. Everyone's different.
Everyone's different.
And thanks to GLP-1s and Ozempic and Wegovy and Zepbound and Mounjaro, we can drop your weight. I mean, so don't stress. Enjoy pregnancy.
Yourself.
And don't be tough on yourself.
What do you think about hormonal therapy after menopause?
So, you can't put everyone, and you can't treat every single woman the same. We used to do that. We would put everyone on hormones, and then we stopped putting everyone and all these patients on hormones. And now in my practice, I listen to my patients. One thing that it's important to know is for patients who have the ApoE4 gene, these patients are at risk of dementia and Alzheimer's. And we know that these patients will benefit from HRT the first 7 to 8 years postpartum. So if they don't have any risk factors for HRT, then I would, usually check my patients. If they have the gene mutation, I would give them HRT. Patients who have hot flashes, severe depression, night sweat, bad osteoporosis. There's so many symptoms. HRT really makes a difference. You use it. It's a game changer for a lot of patients, but it's important to listen to the patient's symptoms, see what it is that they're trying to treat. Do they have symptoms? Do they need to be on it? I've had breast cancer. My breast cancer was estrogen receptor positive. No, I cannot be on HRT. So you can't treat everyone the same.
Okay, I definitely want this question because I remember when I first started estrogen, I started popping the things all over because I was like, if I put a lot of them on, then I'm going to feel so much better. So, what is the correct dosage of estrogen and progesterone for most women? Can you take too much? If you do, what happens to you?
Very good question. First of all, it depends whether you have a uterus or you don't. If you do not have a uterus, you don't need the progesterone. You can just do the estrogen patches or take estrogen by mouth. The reason we add progesterone is because unopposed estrogen can cause the lining of your uterus to get thick and eventually can cause hyperplasia and then possibly uterine cancer. So by adding progesterone, we block that, right?
But progesterone makes me sleep. It helps me sleep.
You can
Okay.
do natural progesterone, but the combination estrogen and progesterone patches or hormone pills, the reason there is progesterone is to basically balance the effect of estrogen on the lining of the uterus. Now, so let's take a woman with a uterus.
Okay.
Usually you start them on HRT. I like using estrogen as a form of patch because when you take estrogen orally, it can increase your risk of blood clots.
Right.
Patients who travel a lot, they sit in their chair for a long time, or do you know what I'm saying? So if you're at risk of any blood clots, then I rather do the estrogen as a form of a patch. These patches, you can either change them by twice a week or once a week, right? And then you can do the progesterone, like 100 milligrams once a day by mouth. But the dosage of the progesterone patch or the pill has to do with the symptoms and your risk factors.
Okay.
Right? So for example, if usually I start with an average dose patch of 0.05, let's say, and the patient comes back and says, I'm not feeling better. I'm still having hot flashes. I go up.
Okay.
Younger patients, I do a higher dose for women who go through menopause a little bit earlier. But generally speaking, for me, I try to use the lowest dose of hormones needed to resolve the patient's symptoms.
So it's symptom related.
Right.
You
And
start
don't
low,
just,
and if you
yes,
feel better, and putting 7 patches on you is not
it's not going to solve this. It's not going to solve the problem.
What's your take on weight loss medications like Ozempic for perimenopausal women who have gained weight?
I absolutely love it. And, you know, it breaks my heart when I see all these negative comments about these GLP-1 medications. As you know, I've been using these medications since 2014. So in 2014, my own family members would, lost like 50 pounds, 60 pounds. So these medications have been around for many years. They've just gotten better and better. I started using Trulicity. Then from Trulicity, I went to Victoza, to Saxenda, to Ozempic, to Wegovy, to Mounjaro, to Zepbound. So these medications they're just getting better and better. They work better. You have to remember, as we go through menopause, in the perimenopause stage, which is 7 to 10 years before menopause, women go through premenopause. Average age of menopause is 51 and a half. So
That's 10 years that you're going through perimenopause.
Right. And you notice your weight's going up, up. So, we talked about this, but you can check to make sure if you have family history of diabetes, if you have insulin resistance, if you had PCOS in your life, you probably are going to gain more and more weight as you go through menopause. So using these medications to regulate a patient's weight are absolutely safe. Absolutely safe.
Okay.
The problem is there's a shortage right now. So we want to use the meds for our obese patients. And sometimes, when patients who want to lose 10 pounds and they go on these medications, they're taking medication away from.
So what do you do in that situation?
My practice is different, but as I'm just hoping that they're going to manufacture more of these meds and this shortage will be resolved at some point.
Yeah.
So everyone could have access.
Everyone can have access. Yeah. I'm almost 50 and I'm dealing with severe hair shedding and very low metabolism. Help.
Welcome to menopause.
Okay. Welcome to menopause.
Range of menopause is 45 to 55. Average is 51 and a half. So at 50, right, I would be curious to know when her last period was. She's definitely perimenopausal or menopausal. And what happens is you get hair thinning, you get hair loss, your weight goes up. We just talked about weight. You can use diet, exercise. I always say to maintain your weight after menopause, I swear, you have to exercise twice, eat half, just to maintain it, not to lose it.
Yeah.
That's how difficult it gets after menopause. So exercise is so important. Your diet is very important. Cut down on carbohydrates, on sugars, and if you still, if you can't, you lose it, then we go to medications.
Okay. Well, I love this one. What vitamin should I be taking for my PCOS? What are your thoughts on inositol and berberine?
Do you want to answer
I
that,
would
Dr.
love to talk about
Haney?
this. So it's not going to come out yet, so we don't want to talk too much about it, but we are developing a supplement that is going to be a natural option for girls and women with PCOS. So
Or insulin
or
resistance.
insulin resistant or everything. So inositol is one of the ingredients in it, which has been proven in study after study after study. And berberine is not in ours, but it's another supplement that has been used as quote unquote a natural Ozempic, but there is some discrepancies.
Long-term,
there are some long-term
yes.
problems with that.
I really, and I'm not just saying this all natural supplement that we're coming out with will be a game changer. But I want patients to use it, try it, and see exactly what it does. It will be almost, I'm hoping, obviously you have to have thousands and thousands of patients try it, but I'm hoping that it would be close to what metformin does for these patients. And metformin has a lot of side effects. I love metformin for PCOS patients, but it can give them nausea, diarrhea. I gave one metformin pill. As you know, I have insulin resistance and I take it every night for anti-aging and longevity because I have insulin resistance. And we were in Paris and my husband said, well, what are you doing? I'm like, you want to try it? I gave him one pill at night and the next morning he was bedridden, curled up on the floor in the hotel. So that is, some patients do react
side
that
effects,
way.
right?
And it ruined his entire day. Granted, it gets better. People will get used to it. And men, of course, they're more dramatic than women.
Yes, they are.
But hopefully this supplement can replace metformin for a lot of these patients.
What are your chances of getting throat cancer from oral sex?
So it all depends on whether or not you're getting infected with HPV 16 and 18. I don't know if you know this, but gynecologists have a higher risk of throat cancer because of all these procedures we do. I've done thousands of colposcopies and, probably, I don't know, thousands of leaps. And every time you do that, you probably release the virus. And I used to go to an ENT and have him look at my throat because HPV 16 and 18 have been associated with throat cancer. But it's not something that we want people to worry about. And there's, if your partner or yourself, you've been diagnosed with HPV 16 and 18, you can see an ENT. Just to be safe, but it's not something you need to do routinely.
Well, do you want your partner to get tested for those two things?
There is no HPV test for men.
There's no.
Isn't that terrible?
This is crazy.
You can swab, you can push a swab all the way up the penis, but no one's going to let you do that.
Nobody's going to let you do that. I can promise you that.
I would love to have him do that, though, for giving HPV to us. But until we have an HPV test for men, the only way to diagnose it is by testing women.
I did not know that. That is, I've learned so much from you, but I actually did not know there was no test for HPV for men.
We're not talking about herpes. This is HPV.
Right, not herpes, HPV. What are the effects of Ozempic on egg freezing, or are there?
I mean, I don't know that there's an effect directly. I'm not aware of it. I don't think anyone is. We need more studies on that. But one thing's for sure, Ozempic is helping patients lose weight, especially PCOS patients. By losing weight, we can make their periods a little bit more regular, and it will optimize their egg freezing and definitely optimize their pregnancy. I usually want my patients to be less than 200 pounds if they're trying to get pregnant.
Okay. What foods should pregnant women with PCOS avoid?
Carbs, sugar.
Okay. Yeah. It's insulin resistance.
Right.
Insulin. Okay.
Right. And for these PCOS patients, like I said, I do gestational diabetes test twice in pregnancy, once early on at around 12 weeks and once between 24 to 28 weeks.
Okay. Is metformin Ozempic safe to take while breastfeeding and pregnant?
So metformin you can take during pregnancy, but you're not supposed to because we
Okay.
don't want to mask gestational diabetes. Basically, if you have PCOS and you're on metformin and you get pregnant, usually I have my patients stop the metformin, and at 12 weeks I check for gestational diabetes, and then I check them again between 24 to 28 weeks. If they do get diagnosed with gestational diabetes, and we start with diet, and if their blood sugars keep going up, then we have to intervene with medication like glyburide, or sometimes we switch to insulin. Ozempic is not allowed in pregnancy. It's not allowed during breastfeeding, but metformin is absolutely allowed during breastfeeding.
Okay. I'm in my 20s and I've had multiple miscarriages, including an ectopic pregnancy. What are treatment plan steps?
What do you think her diagnosis is?
She has endometriosis
That's number one on the list.
or
She could
PCOS.
probably
Probably endo.
endometriosis. Why? Because she had an ectopic pregnancy, so she
Mhm.
probably has inflammation. She has scarring of her tubes. Multiple miscarriages could also be autoimmune. I want to do a full infertility. I'm not an infertility doctor, but I'm really good at it. There's
Mhm.
not a single patient that comes to my office with infertility that I cannot tell them why they're infertile. I'm really
Mhm.
good at that, and I want to do an episode on that.
Okay.
But just to go back on this patient, um, ectopic. So whenever you talk just quickly about fertility, the first thing you want to check is you want to make sure their egg count is good and their hormones are good. I call that female factor. Second is male factor. Infertility, you want to make sure the sperm is good, right? Um, Men are always pointing fingers at us that, they don't even associate
It's
infertility
not
with it.
me.
Yes,
Mhm.
always. So you want to make sure, number two, male factor,
Right.
the semen analysis is normal. Number three, we call it tubal factors. Are the tubes open? Are they scarred? Tubal factor is your anatomy. Are there polyps in the uterus? Do you have fibroids in the wall of the uterus? Is there adenomyosis, which means the walls of the uterus are
Mhm.
very glandular, and
Mhm.
sometimes that can increase the risk of miscarriages. Are the tubes open? So that's your tubal factor. Then number four is, does this patient have endometriosis? Number five is, does this patient have polycystic ovarian syndrome? And number six is autoimmune workup. Someone who has multiple miscarriages, it could be endometriosis, it could be adenomyosis, because when the walls of the uterus are glandular, you're at risk of having a miscarriage. But if you have an underlying autoimmune disorder like lupus, antiphospholipid syndrome, I mean, the list goes on and on. What happens is your body attacks the pregnancy. These are the patients who fall into the unexplained a lot of times, and they get blood thinners like Lovenox, and they basically are able to get pregnant and keep that pregnancy. But you have to go through that quick workup, as I just mentioned it.
I love this question because we talk a lot about PCOS and young girls that have eating disorders and a lot of anxiety and depression that are undiagnosed with PCOS. So, what are the best and worst antidepressants for PCOS?
So PCOS patients who are very depressed or anxious, it's very important for them to be seen by a psychiatrist and get diagnosed. Especially if they want to get pregnant, I start them on Zoloft. But if, to answer this woman's question, if she's not feeling better, she needs to be evaluated by a psychiatrist.
And what about young girls?
I would probably use Lexapro. I love Lexapro. It's because a lot of young girls are very anxious, and
Yeah.
anxiety
Yeah.
takes you down. So a very low dose of Lexapro goes a long way with these patients. The one key thing I want patients to understand is Lexapro is for anxiety. However, the first 2 weeks, it can take your anxiety really high before it brings
Okay.
it down. To avoid that peak, a lot of people take it for 2 weeks, they get so anxious and they stop it. So how do you avoid that? You cut the pill into quarters. The first week, you only take a quarter a day. The lowest dose of Lexapro is 10 milligrams. Take a quarter a day for a week. The second week, you can go to half a pill, which is 5 milligram a day for a week, and then you go to the 10 milligram. And when you treat anxiety and depression, you have to give yourself 6 to 8 weeks. These medications don't work over time. So I always say do it for 6 to 8 weeks. If it doesn't work, put it in trash. But if it works, you have to stay on it. And I just want people to know that these medications are non-addictive. So I have patients that are like, I don't want Lexapro because I take Xanax. That's not okay. Xanax, Ativan, diazepam, Valium, these are all highly, highly addictive.
Right.
Do not use it for anxiety. I rather have my daughter on Lexapro than any of these medications that are highly addictive.
Right. And as with everything, we are not diagnosing you. We are not any of your doctors. Anyone that's answering this, you need to talk to your own doctor. But these are great things to arm yourself with to walk in there. My daughter is 19 and her period is never on time. Sometimes it's 6 months late. What should she do?
What is her diagnosis, Mary Alice?
PCOS.
Most likely, right? But you have to evaluate her. You have to do an ultra. Endometriosis doesn't cause irregular periods. No, it causes painful, heavy periods. Polycystic ovarian syndrome is on top of your list. You have to make sure her thyroid is normal. You have to make sure her prolactin is normal. So you can check her testosterone. So you want to do a full hormone panel on her. But teenagers, we don't worry when teenagers have irregular periods. Just like when a toddler starts walking, they take 2 steps and they fall, and then take 3 steps and they fall. Your brain is trying to connect to your ovary, and your ovary is trying to connect to your uterus. So from 12.4, which is average age of menarche when girls get their period, to about age 18 and 19, it's okay to have irregular periods. But if that irregular period is also associated with acne, hair loss, facial hair, body hair, weight gain, then you're dealing with PCOS.
And we're going to be doing a lot of episodes on PCOS because it's
my passion.
It's your passion. And 75% of women go undiagnosed. We got through these questions and we keep getting them every day. And I feel so blessed that we have these listeners that really, want to arm themselves and be their own health advocates. So if you have questions and you want Dr. A to answer them, go to info@shemdpodcast.com and we're going to really try to get to every single one.
And, I just ask patients not to go to my Instagram and send me messages. Maybe we can have someone go through those messages because I get a lot of questions there too. So this is a better place because I don't have time to check my messages on Instagram. But if you guys come here, I'll try to answer all of them.
We're going to try to, because this is our life mission, to make you your own health advocate. This was so much fun. We got through our first Ask Me Anything episode. Thanks so much for joining us today on SHEMD. And remember, if you want to own your own health, a good place to start is by following us on social media at SHEMD Podcast and by subscribing to our show on YouTube. And don't forget, you can listen to our episodes on Apple, Spotify, or wherever you get your podcasts. For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SHEMD.